So, hello everyone. Well, welcome to our October session of the lung cancer webinar, sponsored through MOASC. And again, this topic that we'll be discussing today will be on unresectable stage 3 um, lung cancer. We have the esteemed pleasure of having two radiation oncologists to help guide us through some of the treatment discussions and important pearls that are needed to really kind of further assess the best treatment strategy for unresectable patients, particularly those with stage 3. So without further ado, I'd like to introduce Dr. Peter Chen, who is a practicing radiation oncologist at the Scripps MD Anderson Hospital here in San Diego, and Dr. Ajay Sandhu, who is also a radiation oncologist here at UCSD, a professor of radiation oncology. So without further ado, actually, I'll turn it over to Dr. Chen. Thank you so much for volunteering to present some slides as we get started in some of the discussion points.
Thank you, Dr. Husain. It's a pleasure to meet you all, and I'll start off with a few slides that I prepared. Everyone see some slides, or at least a slide?
Yeah, we can see them.
So today I'll just go through some of the, I'll first start off what the current standard is and where the data came from that established this current standard, and then go into how things potentially could improve upon the current standard. So I have no disclosures, and as everyone knows here from the NCCN guidelines, for unresectable non-small cell stage 3 lung cancer, the current standard is to do definitive concurrent chemoradiation followed by durvalumab, and that's partly based on a few clinical trials. One of the big ones was RTOG 9410 that established concurrent chemoradiation was superior to doing a sequential chemoradiation. And although this trial had 3 arms, the most important thing to take out from it was this figure that when comparing sequential versus concurrent chemoradiation, that the 5-year overall survival was better in the concurrent arm, 16% versus 10%. And just kind of remember these numbers because as we go along and we see more modern trials, we'll see that these numbers will improve. So trying to improve upon that, people started thinking about, can you dose escalate in radiation, because we always feel that maybe a higher dose radiation can confer a better local control that might then lead to an improved survival benefit or a progression-free survival. So this trial, RTOG 0617, is important, at least in the radiation world, was this established the standard dose that we use for stage 3 lung cancer at 60 gray. And so this trial compared 2 different doses, 60 gray versus 74 gray, where we were trying to see if a higher dose would improve survival, but actually in this case we saw that it didn't. And so this is an important trial because it actually used modern techniques, whereas that original 9410 trial used a little bit older techniques like 3D conformal mostly, whereas this is a modern trial. So the 5-year overall survival for this was around 32% for the standard arm, the 60 gray arm. And that's another number to kind of remember. And in order to improve upon that, this specific trial, adding adjuvant immunotherapy established that we could improve on those survival numbers. And the basic gist of this trial was after concurrent chemoradiation, people were randomized to durvalumab or placebo. And if you look at the 5-year overall survival numbers, with durvalumab, it was 43% versus 33%. So it added about 10% benefit to the overall survival numbers compared to standard chemoradiation. And this was a good trial because actually all the numbers were consistent with and in line with what was seen in RTOG 0617. So since then, there were also a few other trials looking at other anti-PD-L1 consolidation. The Gemstone 301 trial from China looked at this, and it kind of also supported this idea of adding consolidative immunotherapy for unresectable stage 3 lung cancer. Since then, there's been a lot of interest in incorporating checkpoint inhibitors in unresectable stage 3. So this is kind of a big overall picture of all the different strategies that people are using or at least thinking about. So one approach to try to improve upon the current standard was to intensify the consolidative immunotherapy. And one of those trials was the COAST trial, the phase 2 trial that compared consolidated durvalumab versus consolidated durvalumab with other immunotherapies. And they did see some ORR, some response. So there was some interest in doing this approach of intensifying the consolidation with immunotherapy. But another concept that I think maybe also it may pan out a little bit better is the role of concurrent immunotherapy with chemoradiation versus just the standard. And so this is a table that kind of summarizes some of the trials, phase 2 trials have been done. And it's an interesting table because it compares it to the standard RTOG 0617 numbers. So these 3 trials, the Keynote 799, the Deterred Part 2 trial, and the Nicholas trial, they all incorporated different checkpoint inhibitors with concurrent chemoradiation. And so if we look at the RTOG 0617 one-year progression-free numbers, is around 50%, with one-year overall survival of 80%. Keynote 799 trial, at the same one-year progression-free numbers, it was significantly higher compared to 0617, but the survival numbers were comparable to the standard arm. In this trial, the Keynote 799, they used pembrolizumab as the checkpoint inhibitor. Deterred, they used atezolizumab, and this one, in this trial, the progression-free survival and overall survival numbers were pretty much the same as the RTOG 0617 standard chemoradiation alone arm, so it didn't seem like it was a significant benefit. And in the Nicholas trial, they used nivolumab, and similarly to the Deterred Part 2, not much of a benefit, but the Keynote 799 did show some improvement compared to 0617, so there's still some interest in pursuing this approach of doing concurrent immunotherapy with radiation. So another strategy that people have been looking at, and there's some phase 2 trials now, is doing induction immunotherapy followed by chemoradiation, followed by consolidative checkpoint inhibitors. And one of that was the Apollo trial, and some other ones were the Daedalus, Bridge, and the Pacific trials. Not much data yet so far, but these studies being done. Then there's another approach where instead of adding any chemotherapy, another approach is just doing immunotherapy alone with radiation. And so the AST16 trial used 4 cycles of atezolizumab followed by concurrent chemoradiation, followed by consolidative adjuvant immunotherapy, and they did see a pretty good median progression-free survival with 84% of patients alive at 18 months. Another strategy was in the SPRINT phase 2 trial where they started off with 3 cycles of pembrolizumab, followed by just radiation alone, followed by pembrolizumab, and they saw some pretty reasonable numbers. So the SPRINT trial, as the name suggests, they were trying to finish the radiation very quickly. And interestingly enough, in this trial, there was no chemo involved, just immunotherapy and radiation. And the radiation they used was also hypofractionated rather than in the standard radiation approaches. We usually use 30 treatments to spray. In this trial, they only did 20 fractions or 20 treatments to an overall dose of 55 grays. So they're really trying to finish all the treatment as quick as possible. So those are kind of some of the different strategies.
Yeah.
Sure.
Yeah. No, thank you. That was a wonderful introduction to just the complexity and also, the fact that the field has really, considered how just from sequential to concurrent to consolidative immune therapy, and then now concurrent with immune therapy, I may just take a quick pause and say, I think some key points that I'd love to kind of generate discussion around are so the first being there are many patients actually in whom it becomes challenging to think through both concurrent chemotherapy and radiation. Like I'll give you an example. I have a patient who is oxygen dependent. You know, he is obese and morbidly obese, and there's a lot of concerns around some of the toxicity with the concurrent approach. Um, Under what circumstances do you think through just a single modality with just radiation versus concurrent chemorads? How does that decision play out in the room and kind of in your multidisciplinary team?
Yes, for us, I think deciding between radiation alone versus chemoradiation for unresectable stage 3, I think baseline pulmonary function tests, that's one thing we will look at, age, and a lot of the comorbidities. So I think for us, radiation oncologists, I think the most important thing is how much pulmonary reserve there is. So in terms of the chemo aspect, I think that's more of, I would defer to the medical oncologist, but I think for that, usually if the kidney function is okay, generally speaking, the pulmonary function is okay, we'll do the concurrent chemoradiation. I think for older patients who have, let's say, poor kidney function, then those we actually may consider just doing radiation alone.
That's super helpful, actually. I think so. It sounds like, what really kind of determines the radiation plan is the pulmonary function. Sounds like what could really determine the chemotherapy plan being more performance status, kidney function. Um, I think in my practice, actually, I think certain things that we have sometimes seen a lot is cytopenias through the therapy, and getting patients through that can be challenging. Dr. Sandhu, any thoughts you have or want to share about patients in whom maybe the right candidates for, say, a radiation alone type of strategy versus chemotherapy and radiation?
Yeah, I mean, I agree. The most important is performance status, weight loss, and I think the decision that sometimes you have to make sitting in the clinic is whether it's even worthwhile doing a curative approach versus palliative approach. Even though it may seem a simple question, it's sometimes very difficult. And many times, I do like a split course palliative in patients who still have stage 3 disease, but they have poor performance status. So we do radiation, see first course, see how they're doing, wait for a couple of weeks, and if they're improved, their tumor shrinks, then we do another course, which of course is more palliative rather than a curative.
That's a wonderful point.
And so, but
Hmm.
yeah, if they have of disease, depending on their performance status. Certainly, if they're not chemoradiation candidate, many times we do definitive radiation alone also. Of course, which is not optimal, but many patients are not suitable for more aggressive approach.
And I'd love to get both of your opinions on this point. So I have a patient who I described actually, as for some reason being higher risk with the concurrent approach. The question comes up is this patient a patient who may get access, or kind of under what circumstances would immune therapy as consolidative treatment be considered? And I think from a conceptual standpoint, we know that radiation can induce an inflammatory response within the cancer, cause a certain amount of cell death within the cancer that can be immunogenic. Um, what are your thoughts about those patients who, for whatever reason, may have disease that may be definitively treated, but may not be good candidates for chemo? Is immune therapy still a viable option to consider for those patients?
That's mostly a kind of medical oncology question, but I think, I mean, most of data obviously for at least for consolidative immuno comes from chemoradiation patients rather than from radiation alone patients. But I guess you could apply the same principle. But my question is, if they're not suitable for concurrent chemoradiation, sometimes we also follow sequential approach. May do chemo first and then do radiation. I mean, if they can tolerate chemotherapy alone. But then, yeah, but definitely, I mean, there's a question about whether they should get immunotherapy. If they can, I always favor that.
Yeah.
I don't think we have very good data on that, but I think it makes sense.
Yeah.
So in terms of if someone has completed a course of radiation and if you wanted to consolidate with immunotherapy, I think the only data, at least phase 2 data that we have, although not in the stage 3 lung cancer patients, but in stage 1 lung cancer patients, to kind of extrapolate, Dr. Chang from MD Anderson, he, I think recently just published in Lancet their experience for stage 1 and I think even smaller stage 2 lung cancer, early stage lung cancer that was treated with SBRT alone. They wanted to see if the addition of checkpoint inhibitors as consolidation would improve outcomes. And in that trial, they did that and they published data and improved the overall survival from 50-something% at 5 years or so up to 70-something%. And the risk of pneumonitis in those cases was relatively low, I think around 3%. The Pacific trial, the rate of pneumonitis was around 7% or so, I believe. So I think the main challenge for adding consolidated radiation that we always worry about is how much volume did we irradiate. And so in the phase 2 trial that Dr. Chang published in Lancet, with SBRT, you're treating small volumes. So I think maybe that's why they didn't see as much pneumonitis by adding the consolidative checkpoint inhibitors. In the stage 3 setting, if you're treating a larger volume, like you're treating the lymph nodes and the primary disease, then you could see maybe a little bit higher rate, but still, even from the data from Pacific, the rate of pneumonitis was around 7 to 10%, so not super high. So I think if a patient's pulmonary status is good and they tolerate the radiation, and let's say the volume isn't too big, then I think it's not unreasonable to add consolidative immunotherapy.
Yeah, no, those are excellent points.
I mean, that's a very
and thank you.
important point. I think
no,
there was always concern about toxicity.
Yeah. No, I think, excellent points.
Go ahead.
And yeah, no, sorry, Ajay, actually, just to kind of interject the point that, really excellent points around, the fact actually that in the Pacific study, some key takeaway messages are the rates of pneumonitis for grade 3 toxicity are pretty comparable across the arm that received the Pacific regimen versus the control. I think some other key points in the Pacific that get discussed are the timing to immune therapy. If patients received immune therapy within 2 weeks of completion of chemoradiation, those patients, generally performed better than the patients actually who were, treated at longer intervals, even though the FDA-approved label allows for not a time restriction on the administration of the immune therapy. And then I think some other points are that what we have just discussed is perhaps there are certain circumstances where patients may be treated with a curative intent, but sequential chemotherapy or delayed chemotherapy or no chemotherapy. Right now, the FDA approval for durvalumab is consolidative immune therapy is after concurrent chemoradiation. And so, again, those would be off label, but they do come up. And, I am currently in that situation actually with the patient to talk through the applicability of consolidative therapy with immune therapy in this setting. there are certain subgroups of patients that perform less well with um, consolidated durvalumab after chemoradiation. Those patients may be PD-L1 negative patients or and or EGFR patients. And I think we can have a little bit more discussion on those points, to see if there's ways to enhance the strategy forward for those patients. And I think some other key points to mention are patients were included in Pacific if they had no progression after the chemoradiation. And so I think some things that we often think through are when should we be doing CT scans post chemoradiation? Should this be, and I think Ajay, we have considered doing scans, you know, um, I think one number that we talk about a lot is 4 weeks after the chemoradiation. But now some points are about, if we want to start the immune therapy sooner and we want to get a scan sooner, really kind of, at least in my mind, what that is translating to is just making sure there's no other distant metastatic spread or another pulmonary lesion that's not in the radiation field or something like that being the primary areas that we're looking at and not really focusing on the tumor itself. So those are some other points from Pacific that are very important to raise as well. But love to get your take on any of the comments I've just made about Pacific.
So in regards to the patients who, let's say, have an actionable driver mutation, that's a good point. Actually, in the deterred Part 2 trial that was looking at concurrent immunotherapy with chemoradiation, they saw that the presence of a targetable driver oncogene mutation led to a worse progression-free survival. So that actually leads to one of my other slides here, where so some people had looked into the role of TKIs for patients who, let's say, had an EGFR driver mutation. And although this study looked at resectable patients, this then led to a trial called the LAURA trial. So in this study, they had stage 1B to 3A patients that were resected and had confirmed EGFR mutations, found that adding osimertinib conferred a significant survival benefit compared to no osimertinib. So that has kind of led to this thought of what about TKI consolidation for unresectable stage 3 lung cancer patients. So in this trial that's ongoing, patients would get concurrent chemoradiation, but instead of consolidative durvalumab, these patients, because they had EGFR mutations, they were randomized to osimertinib versus. So this trial will help answer that question.
No, that's an excellent point. And Peter, I may ask you about this actually. In these patients who are resectable or borderline resectable, I think one one question that comes up is that, should these patients be getting a neoadjuvant strategy? And then, decision made at Scripps, MD Anderson. How are you guys juggling that? I know, and we can comment here from UCSD's perspective, but how are you thinking through in discussions with the surgeons how to establish the paradigm for patients? One being treating with chemoradiation for those patients who are deemed unresectable at one point in time, or kind of more of a philosophy of saying patients may be borderline resectable and let's see how they do with neoadjuvant therapies and then making a decision. How have you guys been tackling these questions in your tumor boards?
Yeah, so this idea of resectability is kind of a moving target. It's really evolving. I think in the past, my thought process and our tumor board thought process is anything that's multi-stage N2 or multiple nodes, you usually those we generally think of them as unresectable. But for potentially resectable, we usually think of single station N2 or less, and common status. So kind of like this patient here, basically this is a stage 3A patient with a T4 tumor and N1 disease only, but it's stage 3, and they have good pulmonary function status, and relatively young patient. Those we feel that would be potentially resectable. And so for the potentially resectable patients, then nowadays we do at least discuss doing the neoadjuvant chemoimmunotherapy approach that the Checkmate 816 showed was beneficial compared to just surgery alone. So usually for these resectable patients, then we'll at least discuss that option with the patient.
I think that's great. And if a patient was borderline resectable or technically not resectable at that point, but perhaps a feeling that the patient would become resectable with therapy, how would you juggle that circumstance within your multidisciplinary team?
We usually have the patients see both the surgeons and us, and if the surgeon feels that potentially they could eventually turn resectable, let's say if the tumor was in just one lobe, then I would say usually we'll at least give the patient the benefit of the doubt and at least start them on neoadjuvant treatments and see if after a few cycles and then a scan if the surgeon feels that at that point. But if it's a tumor that, let's say, is riding on the fissure, it's relatively big, very central, in a neoadjuvant approach, if let's say the surgeon said that potentially they're resectable, in those cases, I would usually argue that although that's potentially resectable, if the tumor is very central, even if the tumor shrinks and they do surgery, a lot of times if it's right up against the hilum, surgery you're going to do is potentially a pneumonectomy. And so if it's a left-sided pneumonectomy for a young patient, maybe they could tolerate it, but if it's a right pneumonectomy, I would usually argue to just do chemoradiation, not even bother doing the adjuvant approach.
Oh, excellent points. And thank you so much for sharing. I think one of the key points is, how we articulate and kind of come to these decisions as a multidisciplinary team, kind of within each of our institutes and among the people that we work with. Ajay, I may ask you actually. I know that we've participated a lot on the on our tumor boards. How do you feel like these questions get vetted in our tumor boards at UCSD?
So I really want to say quite a bit on that, because it's a very contentious issue. And what happens is that sometimes surgeons kind of go overboard, because the reason is the data is only for resectable. So in that trial, they were resectable to start with, and then had all the therapy. Now the data doesn't support that a borderline or unresectable, if you want to convert, that sometimes can be detrimental, because, and we have seen that in our practice, doctors, and you remember too, so many times they start on neoadjuvant approach, and then patient still remains unresectable, and now patient has progressed sometimes during treatment. Now you lost opportunity for definitive chemoradiation for a curative approach. So, and also, there's a European study which showed that if they're unresectable or borderline resectable, or even resectable, if you give a neoadjuvant chemo followed by surgery versus chemoradiation, usually there's not much difference in survival. So I think it's very important to select patients appropriately for neoadjuvant approach followed by surgery. We should not do it routinely like that. Surgeons can say, okay, let's try.
Yeah, I like to echo that point too, because look, I have a few slides from the Checkmate trial, and basically found that the progression-free survival numbers it's actually not that much different compared to just the standard chemoradiation arm, and so with durvalumab. And so I think, yeah, I agree with Dr. Sandhu that unless the patient up front is truly resectable, I think it would probably just still do concurrent chemoradiation as a standard of practice. because yeah, I don't, because this Checkmate 816 doesn't even compare the outcomes compared to say if the patient were randomized to say chemoradiation. If you actually look at the outcomes with the median EFS with adjuvant approach and surgery, it was 32%, but for the 5-year progression-free survival with radiation and durvalumab, it was 33%. So yeah, I think they actually did, let's say, a head-to-head phase 3 trial of this approach for potentially resectable patients using this neoadjuvant approach with surgery versus, let's say, the standard chemoradiation arm and durvalumab. I don't think you're going to see much of a difference in terms of outcomes. So, I kind of echo.
No, those are very good points. Yeah, those are very good points. And to be honest, it's fantastic to hear, this discussion from a radiation oncology perspective. Sometimes we do hear it a lot from the surgeon, like surgery perspective. And so it's good to kind of have the whole team, kind of sharing a voice. Dr. Chen, what do you think about this point, though, that in Checkmate 816, the slide that you have here, about a third of the patients were still stage 1B to 2. And, I think along those lines, I think it is curious still, though, that, the event-free survival was lower than, I guess the PFS for the stage 3 patients. So it is curious on that point.
I
But
think
again,
the numbers definitely are kind of buoyed by the kind of early stage patients. So, and I think some of the numbers may be a little bit lower than what we would have wanted to see out of this trial, maybe as a perioperative risk that had anything that could have affected these numbers compared to, say, chemoradiation.
So I think a take-home point here is that, the establishment of resectability is a key point. I think that for those patients who are resectable, surgery and or neoadjuvant approaches, is a standard. From what I'm also hearing is that trying to make patients or convert patients to be resectable carry some risk in that process. And I think different institutes have different I guess confidences on how one wants to make that call. In our place, I know it is a discussion that happens and can actually be a tense discussion about how to define that resectability. Um, um, because if a patient is not resectable, the hope of making them resectable carries risk as well. So that is one point that gets discussed in our tumor boards. So I think this was, that was great. May I ask, extending on this point, is let's just say, and I know University of Toronto has done a lot with this particular type of paradigm where if patients start with chemoradiation and then there may be like a taking of a decision to do a surgery after chemoradiation. Dr. Chen, I may ask you about this, is that under what circumstances do you see that appropriate? I know some institutes, I believe Dana-Farber and University of Toronto kind of had practice patterns that reflected that. Is that ever something that you would consider for patients actually post-chemo rads?
That's a great question. Where I train at UCSF, we sometimes used to do that. At least from the time that I was there, I remember a few times, and I actually published a paper looking at this issue, was after you do the neoadjuvant chemoradiation and then you go to surgery, usually there was like a lag time of a few weeks to sometimes a month or so, where then we would get a new scan just to see how things responded. But then also trying to get the patient booked for the OR for the surgery sometimes also took some time. And because of the delay, the variable delay, we actually saw that in a portion of patients, there was peak growth of the tumor. And so it kind of negated some of the benefit of doing the neoadjuvant chemoradiation. So I think if a program is going to do a neoadjuvant chemoradiation approach followed by surgery, usually it should be kind of a predetermined date, like after the chemoradiation, you already know you're going to do surgery. It's not like a wait and see, like hoping that the chemoradiation is going to make something unresectable becoming resectable because of that chance of regrowth. So here we tend not to do that. So usually if upfront, if we decide that this patient is resectable, then they'll probably just do neoadjuvant chemoimmunotherapy and then go to surgery, plan surgery, unless, of course, we see something different or is not responding, then sometimes we have switched from that surgical approach to just switching to concurrent chemo.
No, that's an excellent point. Yeah, I think at UCSD, I don't believe we've done much of that approach. Dr. Sandhu, any experiences you've had where patients have gotten chemoradiation and then either decisions for surgery or some other decision taken post-chemo rats?
So I think I agree with Dr. Chen. So it is institution dependent. And going back to, idea of unresectable or borderline having surgery, I think it makes sense for those patients to undergo chemoradiation first. And then if, they have like very localized, residual disease or persistent disease, then in a select patient, certainly you could do surgery. And it's also surgeon dependent as well. Many surgeons don't feel comfortable doing surgery after full dose radiation. On the other hand, I mean, there's data to support that salvage surgery can be done in select patients with success and with not that higher toxicity. So I think we used to do it. Dr. Periconi, I don't know if you remember, he retired. He was a proponent of that. He would always tell us to give full dose chemoradiation if he felt that surgery upfront is not an option, and then he will reassess patients in few weeks after completion. We'll do reimaging, and if there's complete response or the tumor is gone, then usually we leave it there because I don't think there's any advantage of doing surgery if there's no residual disease. But again, I think neoadjuvant radiation has kind of gone out of favor now, so we hardly ever do that.
Yeah. No, I think that's really important to think through. I think it'd be curious to see how um, now with um, more dialogues with the surgeons and how the systemic therapies are also becoming more familiarized with the surgeons, um, how some of these approaches, may be revived or kind of at least considered in different ways as well, and what the benchmarks are. I think some key points that from a post surgery standpoint that are looked at are whether or not patients have had pathological responses in the cancers based on the neoadjuvant therapy administered. And, there may be some considerations about how one may also think through those endpoints with chemoradiation as well. Okay. I may actually take another angle and say that there are some ongoing clinical trials looking at how consolidative immune therapy may be given based on biomarkers. And we've spoken about PD-L1, we've spoken about EGFR. Another hot topic is using circulating tumor DNA for MRD to determine which patients should be getting consolidative treatments. Dr. Chen, I may ask you at Scripps, are there any kind of discussions about consolidative immune therapy based on biomarkers such as MRD or anything like that?
Sure, right now, no. I haven't done any of that yet.
Yeah, I know at Stanford, there's currently an ongoing trial actually looking at MRD to base which patients should get consolidated immune therapy after chemoradiation. I think the challenge is that, really, if a patient has clearance of ctDNA, does one want to deprive a patient potentially curative option with immune therapy as consolidative therapy? I think it's going to be an uphill battle to really understand that. And so that is an important point to mention. Um, well, no, I think that that is important. Dr. Chen, I may ask you, in your review of the ongoing studies, you mentioned the COAST study and variety of different new therapies that are being explored in unresectable stage 3. Some of the ones actually that were listed and tested in the COAST study were CD73, and there are some other checkpoints as well. Are you aware of any novel mechanisms outside of PD-1 that may be important as immunomodulatory in the context of radiation? Are there any kind of studies or mechanistic evaluations that are ongoing to perhaps kind of think through novel therapy that may be better radiosensitizers or kind of used in that type of setting?
Yeah, so I think the only other one that may potentially have some role, I guess, comes from the experience in melanomas, where I know in melanomas they use ipilimumab and checkpoint inhibitors, and so I wonder if the CTLA4 target could be explored in unresectable stage 3. In general, I think the most important thing about radiation in terms of helping or synergizing with checkpoint inhibitor responses is just using high enough doses to create some immunologic response. Actually, I have a slide of a recent study, phase 2 study that was presented at ASTRO this year, which is some interesting data where in this phase 2 trial they took all unresectable stage 3 patients, and the premise was that normally we do chemoradiation where the radiation dose is a low dose every day for 30 treatments. This idea of trying to dose escalate has always been somewhat bothersome in our field, where we feel that higher doses should give you better control rates. And we see that in stage 1 lung cancer patients where we give very high doses with SBRT. So there's a thought that can you do SBRT with radiation? And so in this study, what they did was they planned to do SBRT to the primary lung lesion, and then after that, they would do chemoradiation to the mediastinum, to the lymph node, and after that, consolidate with durvalumab. And so basically following the same kind of Pacific trial approach, but the only difference was instead of just doing fractionated radiation to everything, they did SBRT to the primary lung cancer. And by doing so, they actually saw that the 1-year progression-free survival in these patients that received at least one dose of durvalumab was about 70%, and this was even higher than the Pacific trial data at the same time frame. So this definitely was a very interesting study that then has led to this phase 3 trial that they've created, and so this will be an ongoing trial in the future, looking at, instead of adding any additional treatments or medications, it's purely just sequencing different radiation approaches and seeing if that would improve the outcomes. And at least from the phase 2 data, it looks pretty promising.
I think this is super interesting, actually, to think through, really how a more definitive dose at the primary lesion and then chemo rads, for the mediastinum. Is there a thinking that this type of strategy would improve tolerability? Is that kind of one of the circumstances, or is it more how to more effectively dose intensify the areas of where the primary tumor is? Kind of what do you see as like the biggest advantage of this type of strategy?
I think it's primarily just the dose because the dose we give for what we call definitive chemoradiation doses usually is 60 gray based on the RTOG 0617 study. So that's been set as kind of standard. But I think part of the caveat of that lower dose is better was that in that study we're treating a big area. And so if you're giving a low dose every day, it's probably not going to be enough to fully kill off all the cancer cells in the primary tumor. So that's probably going to lead to some local recurrences, which then potentially could impact not only a local regional recurrence, but potentially allow for metastatic recurrence as well. So if one could treat the primary tumor more definitively to a higher dose, I think that's what's conferring this benefit. But in addition to that, I think the higher dose per day that we give in SBRT, that also increases the amount of necrosis in the tumor, and that also may create a more pro-antigenic environment where after we add the durvalumab, it may help the immune system to learn how to recognize the tumor better, and perhaps that also may help improve the effect.
Yeah, that's a really good point.
So one of the interesting things that we've seen in melanoma treatments is this abscopal effect, where if you give treatment radiation to one site after someone has already been on immunotherapy, that the other sites that are untreated by radiation also respond. And so, but that you tend to see that more if you use SBRT level doses, where you give very high doses per day. And so I think that might be contributing to this effect that we're seeing in this study.
Another thing that gets discussed is that the process of how radiation may influence the immune tumor microenvironment. And there's been a lot of speculation about how is radiation actually inducing an immunologic cell death process, or an immunological response. And I've heard two hypotheses. It would be great to get your viewpoint on this. Is that one hypothesis is that the radiation can cause immunogenic cell death and exacerbate immune response. But I've also heard actually that radiation can deplete immune cells at the area that it's being administered, and as such actually may kind of not lead to an immunogenic process, or kind of may actually reduce the inflammation that is pertinent for cell death in the cancer. Do any of those kind of hypotheses resonate more with you? Or is it like a dose dependency that defines what will happen in the tumor microenvironment, with higher dose versus lower dose being more important?
I think definitely the dose per fraction that we use is very important in what we see in terms of an immunologic response, and also a synergistic response with checkpoint inhibitors. So I think definitely dose is an important factor. I think the first theory or concept tends to be what I think is happening, rather than the radiation depleting cells. Although it's true that a lot of the immune cells are very susceptible to radiation damage. Like if we treat the spleen, you'll see the change in the immune cells, even with very, very low doses of radiation. But for tumors, though, I think the microenvironment is very different than what's in the spleen. And so I think I don't think the radiation is going to really change too much of the cells or cause immune depletion in a local environment. I think probably how it's going to work is probably the radiation is, if you use high enough doses of radiation, like with SBRT approaches, probably causing, instead of like a controlled cell death like apoptosis, you're causing more necrosis, and with the necrotic cell death, it's probably a little bit more antigenic, and that is probably what leads to more of an immunologic response.
Well, thank you, Dr. Chen, and thank you, Dr. Sandhu. Actually, I may open it up actually to see if there's any questions in the audience based on some of the topics that we've been discussing here.
Hi, everyone. Hi, this is Ashkan Lashkari. Good evening. I had a question, and that was what are, you know, are we looking at, seeing whether SBRT might provide, or have some role in kind of this, current approach that you have laid out in this trial? Is that something that, is that something that we think that might be a potential standard of care down the road? I mean, I guess the thought is that it may provide some abscopal effect or benefit with the when used in combination with other treatments, whether it's chemotherapy or immunotherapy, or even on its own in terms of generating an immune response. Is that something that you think will kind of be a something that we'll see down the road? And my biggest concern also is with SBRT, whether or not we might see greater side effects in terms of pneumonitis. So I just wanted to get your thoughts on that.
Yeah, absolutely. So I think if the toxicity profile pans out, and from the phase 2 trial, they did look at the rate of pneumonitis, and it was about grade 3 or higher pneumonitis in the phase 2 version of this was around 5%. In the Pacific trial, it was around 3% for grade 3 or higher. So it's maybe a little bit higher, but not super high. So I think if the areas that we're treating are relatively small-ish, I think this will probably hopefully become a new standard, because I think it definitely will confer two potential advantages. One is definitely better local control of the primary tumor. With SBRT, we definitely will have a higher chance of getting rid of the primary tumor. And second of all, I think with the SBRT doses, you may be able to get a more bang for your buck for the logic reaction once you started developing that. So I think the pneumonitis concern, I think, is certainly a valid concern, but I think at least from what the data shows from the phase 2 trial, and at least dosimetrically, just from my experience as well, I think probably we can get away with that. And the reason why I say that is even before this trial was done, in the field, I think people were already trying this kind of off-label sort of where we would do chemoradiation to the mediastinum, but SBRT boost to the primary lesion as a separate course right after finishing the chemoradiation. And we've seen that definitely we could get better local control of the primary. I think we'll see what the phase 3 trial shows, but definitely very exciting data from Astra this year.
And just to clarify, the SBRT is given, is it 3 to 5 treatments like every other day, and so it's given over a short period?
Exactly, yeah. So from the phase 2 design, it was you can give 50 gray in basically 4 fractions, or 54 gray in 3 fractions, or probably for more central tumors, you would do 50 gray in 5 fractions. So between 3 to 5 total SBRT treatment.
Thank you.
Good. Are there any other questions? So if no other questions, actually, I'll just want to thank our panel, both Dr. Chen and Dr. Sandhu. Thank you so much for your participation in helping us really learn some of these nuances as it pertains to the unresectable stage 3 patient population, and specifically the role of chemoradiation and radiation as a whole for these patients. Any last thoughts based on the discussion from you both?
I think, yeah, the most part thing is as we move forward for unresectable stage 3, it's going to definitely be more and more of a collaborative effort between all the specialists, from medical oncologists, radiation oncologists, and even our surgical colleagues. So, yeah, I think the multidisciplinary conference is going to be very colorful as we move forward with more new data. data that comes out.
Thank you, Dr. Chen. Really echo that point as well, is, really being able to, have these multidisciplinary teams speaking about the pros and the cons, and really making sure that everyone's on the same page, I think is a key point. Dr. Sandhu, any other last thoughts on the discussion?
Yeah, I'm sorry, lost a connection for a bit. But I think, like a lot of new and exciting things are happening. I mean, even in early stage now, we have data like Dr. Chen was mentioning, to add immunotherapy to SBRT, and I think in a lot of other trials are testing whether immunotherapy has a abscopal effect or a more effect on even distant metastasis or disease of patient with metastatic disease. We do a lot of SBRT now for oligoprogression or persistent oligopersistent disease. So I think all that adds a lot of exciting things coming in the future.
No, perfect. And then also the role of molecular profiling early and upfront, I think, is a key core theme as well, because we've spoken a lot about the immunological based approaches, but really on the horizon, molecular approaches too that are currently being vetted in this space as well. So with that, actually, thank you so much. And Dr. Lashkari, I'll turn it over to you for closing remarks.
Thank you. Well, I appreciate it. Thank you so much, Dr. Husain. And I know I got on a little bit late, but I did hear the bulk of this discussion between you, Dr. Husain, and our esteemed panelists, Dr. Chen and Dr. Sandhu. I mean, we are so thankful to have you guys here. You guys gave a wonderful presentation. I think having a radiation oncology perspective to the management of unresectable or borderline resectable non-small cell lung cancer is an important area, especially as now we're getting a lot of data being introduced with neoadjuvant chemoimmunotherapy. So the landscape is certainly evolving, but it is so critical to have a good evaluation of these tumors at time of diagnosis to determine the best course of action, since there are a few different courses of action that one can take. So I think it's certainly challenging, and it's certainly helpful for someone like me in the community to listen to you guys. So I really appreciate it. So thank you once again. And I also want to thank our sponsor, AstraZeneca, for hosting our monthly MOASC discussion webinar. We really appreciate your support. And on that note, thank you, everyone. Good night.
Thank you. Good night.
Good night.